musician. Ladies and gentlemen, welcome to another exciting edition of the Sarah Stevenson Tuesday Morning Forum. My name is Winston Robinson. I am a facilitator, along co-facilitators, Ms. Laura McClellan, Ms. Carlene Ivory Canty, Ms. Jackie Edwards Walton, Ms. Natalie McElrath, our timekeeper, Ms. Mary Johnson, Mr. Shea Abdullah, Mr. Gary Young, Dr. Thomas Moore, the in-house musician, Steve Johnson, our website editor and archivist, Ms. Sarita Sherrill, our chaplain. I believe that's it. We got a lot of people in there. All right, our forum runs from 8:30 to 9:45 a.m., at which time we will pause for announcements from the audience. Announcements can also be sent to S. Johnston with a T at TuesdayForumCharlotte.org. We always begin with a prayer, and again, our chaplain is here. Ms. Jackie, are you ready?
Martha.
All right, you pointed at people, okay. All right, Ms. Martha, are you going to lead us in a word of prayer this morning? Get you a summon.
Let us pray. Dear Lord, we thank you for this day. We thank you for the people who are gathered here, who gather on Tuesday mornings for the Sarah Stevenson Forum, a lady we all admired and one of your chosen children. We pray for our speaker today, who is going to remind us of health issues that are important to all of us. And we thank you for the many blessings that you continue to bestow on us. In your name we pray. Amen.
Amen.
Thank you so much, Ms. Martha. All right. Look around. Anybody here for the person? No. Anyway, light room today, again, it's raining and it's cold. However, I know we have an amazing audience online who will be in for a treat because today's guest is none other than Ms. Keisha Lewis, a diabetes coach. And last month was diabetes awareness, right? We got diabetes awareness month. So we brought Keisha in a month after. Make sure you get Thanksgiving out of the way. We want to put that on your mind. So you're going to talk about diabetes. Following the presentation, we will take questions from the audience. Please raise your hand and we will add your name to a list. I will call on you in the order in which your name was added to said list. Questions should be questions and no longer than 30 seconds. Also questions, the answer to your question will be the answer you receive. We do not debate at Tuesday Forum. We have a timekeeper, again, Ms. Natalie McElrath. And without further ado, Ms. Keisha Lewis of Will, here's your microphone because we have a streaming audience that has to hear you.
Okay, can you hear me? Okay. Usually I don't need a microphone because I talk real loud. But today I'm here to talk to you about knowing your risk for diabetes. And so my name is Keisha Lewis. I am the founder of Weldom. And at Weldom, our mission is to eliminate barriers for older adults and individuals with diabetes by bringing mobile services and education to where our clients live, work, and gather. And so it was really important for me to be here today because this is our community and this forum represents our community. And so thank you for having me here today. So I think it's important for you to understand a little bit about how I got here doing diabetes. I took two things that I love, diabetes education and occupational therapy. And that's kind of how I founded Weldom. So growing up in South Carolina, I'm from South Carolina, I got interested in diabetes when I was working in an outpatient therapy clinic. And a lot of my clients, they had diabetes, and I saw a lot of them there for wound care. And at the time, that was lower limb amputations. It was a big problem in the late 90s, the early part of the 2000s. And then I left South Carolina and I moved to the Northern Virginia, Washington, D.C. area. And I worked on the inpatient rehab unit. And I saw many clients there that were impacted by diabetes. And one of the things that I saw was no matter their educational level, whether you were a Stanford graduate and you were living in Washington, D.C., or you were a farmer growing up in South Carolina, if you didn't know what to do to manage your diabetes, then it was going to be a problem. And so for me, it was important to bring education about diabetes and use my skills as an occupational therapist to look at the overall whole person. And that's how I founded Weldom. So thank you again for letting me be here today. And so I'm gonna have some audience participation now. But I just wanna know, how many of you in the room know someone and online that actually has diabetes? All right, yeah. So when you look around the room, it's actually a lot of people that have diabetes, or you know someone impacted by diabetes. And so in 2021, and this is our latest results and studies, 38 million people in the United States were diagnosed with diabetes. And this includes those that were, aware and those that were unaware that they actually had diabetes. Okay, so 38 million people. So diabetes is a public health concern. And that's why diabetes is so important. So when you look at the chart and you see diabetes and then you see pre-diabetes. So I already told you that 38 million people were diagnosed with diabetes. There's another 98 million people that have been diagnosed with pre-diabetes. And that's the condition that can occur before diabetes occurs. So an alarming statistic that I recently heard was that every 17 seconds, someone is diagnosed with diabetes. So when you think about that, that's really that was my aha moment, that something really needed to be done about diabetes. Diabetes is the 8th leading cause of death in the United States, and is actually the 7th leading cause of death in the county. So again, another impactful statement on why diabetes is a public health concern and why we really need to do something to address this issue. Now, diabetes has become the fastest growing chronic condition or chronic disease in the world. Again, in, I believe, 1970s, the Surgeon General at that time identified diabetes as a public health issue. And that has not changed since 1970. And we see these numbers continuing to grow. So with diabetes, there's also an economic impact. So in 2022, over $400 billion was spent for total diabetes care. And people diagnosed with diabetes, they account for 1 in 4 healthcare dollars spent in the United States. We also see that individuals with diabetes, they have increased medical expenses, and the out-of-pocket expenses for things like diabetes medication, seeing their healthcare providers, supplies for strips for testing. That out-of-pocket expense can range anywhere from $3,300 to $4,600 annually for individuals that have diabetes. We also know, and we hear about, because we see this on TV often, that the expensive medications and supplies for diabetes. And so that really is an economic impact on the individual and the society as a whole. So the other thing is that we see that Black Americans with diabetes, they pay the most in direct healthcare costs related to diabetes. And in 2017, diabetes accounted for nearly $11 billion in North Carolina alone. So the next thing we look at is how diabetes impacts communities of color. So data reveals to us that communities of color have a higher burden of diabetes, and they also experience a higher burden of diabetes-related complications. Diabetes, particularly type 2 diabetes, disproportionately affects communities of colors in North Carolina. And despite this, communities of color are less likely to receive recommended diabetes preventative care. So for me, it is important to go into communities of color to be able to bring education regarding diabetes and prevention of complications to the communities that we serve. And it's important for communities to develop strategies and get together to focus on ways to eliminate these barriers and increase the awareness and education and access to services. And so how do we do this? We have to tackle those social determinants of health. So the Healthy People 2030 came up with these impacts on social determinants of health, and they said, hey, we want to work on this. We want to improve access to care. And so when we look at social determinants of health and what those things are, those are the things that are the conditions where people are born, they live, they grow, they work, and they age. So that's why it's important for me to to get out in the community where those people live, work, and gather, to be able to bring this access. And so when you think about it, it doesn't matter what zip code you live in, it doesn't matter how you look, this shouldn't determine your health condition. And oftentimes we see that that does. And so again, we have to be able to find creative ways to get access to the communities that we serve. So I'm gonna use my little wheel here, and I'm gonna take each part of the wheel for the social determinants of health, and I'm gonna break it down a little bit. So the healthcare access and quality. So what does that mean? So the Affordable Care Act expanded opportunities for individuals to be able to obtain affordable health care. It provided a lot of opportunities for education and outreach in communities, especially when individuals didn't have employer-sponsored health care. So what was interesting to me, I did say this earlier, but I moved about 10 months ago now to this area. And so as I expand on my business and what I do, I had to find about statistics in the state of North Carolina. And some of those were really alarming to me. So currently 15% of adults and 8% of children in Mecklenburg County are uninsured. And in North Carolina, 9.2% of individuals don't have health insurance. The national average in the United States is around 8%. So we're exceeding that in the state and we're exceeding that in the county. So when you also look at healthcare access and quality, if I don't have insurance, then I can't make it to the doctor, which is going to create problems, which is going to create burden, which is going to create complications related to diabetes and other chronic conditions. The other problem that I've seen is that there's lack of specialists in the area. There's lack of specialists in the area that look like the communities we serve, that look like me. There's also a lack of the ability to be able to see a physician. So 25.6% of adults do not have a primary care physician. That's 1 in 4 individuals. And moving to this area, I've actually experienced that because I've yet to find a primary care physician. So I was at the State of Diabetes last month actually, and someone brought up the term, and I'm using it now, I'm borrowing it, and that term was medically homeless. So we have individuals in our population that are medically homeless that cannot find a healthcare provider to take care of their needs. So currently right now, I'm medically homeless until I can find a primary care physician. But the wait times to see physicians, it's been alarming to me. The wait times to see specialists, it's even longer. So that's some of the problems when it comes to healthcare access. And then we have quality of care. So if the wait times are long, you can't find a specialty area, that's going to lead to the quality of care that you receive. Now we're going to move around that wheel, and then we're going to go to the neighborhood and the built environment. So the neighborhood and the built environment when it comes to addressing social determinants of health are our neighborhoods safe? Are our neighborhoods accessible? And what that means is actually, do I have safe spaces to walk? Can I exercise? If I have a walker or a cane and I'm trying to get to a bus stop to access transportation, can I actually travel and get over that hump that might be in the sidewalk, that pothole that's across the road? Those are all problems that lead to our neighborhood and built environment. So looking at the community as a whole. And then what does the transportation look like? So can I go outside my senior community? Can I go outside my apartment? Can I get on a bus to be able to get to my medical provider that might be across town because I can't find a provider in my area? So again, access, okay? The next thing as we go around that wheel is we're gonna look at the social and the community context. So with social and community context, as an occupational therapist and working with older adults, I often think about older adults. And so we have an aging population. And so some of those other factors of the neighborhood and the built environment and the healthcare access and quality is going to impact the older adults that are in our communities. Then we have to have knowledge and access to care. So do individuals in our community know what resources exist? what's available to them, and how do they find those services. And a lot of times I find out that most people don't. They don't know the services that's available to them. They don't know, how to reach out for a medical provider. They don't know who the medical provider is sometimes that they need to see. And then we have the issue of racism in society. So again, from a policy standpoint and public policy initiatives to help us be able to reach that social and community context is really important. Then we have a wealth gap in our community, again, which impacts the economics that I talked about earlier. And then we have access to food. So a lot of times with diabetes, I talk about healthy food options and where you go for food options. And so we know right now the cost of food is pretty high. But again, when I talk about those resources again, since I've been here for about 10 months, I do know that there's a lot of community places that you can go to, and there's healthy options for food baskets and fruits and vegetables. I've seen that, and I've participated in giving some of those out. So again, do people have access to get there? Do people know that those things actually exist? And so being able to, share that information with those in the community. And then as we move on around that wheel and we talk about the economic stability, so again, food costs, paying bills, am I going to be able to pay my bills and pay for my prescription medication? Am I going to be able to pay my bills and get healthy meals at the grocery store? So the fact is that 16.4% of individuals, they actually avoid medical care because of the cost. And so medical care is really expensive, then I'm going to take care of my personal needs first. And sometimes medical care is left, it goes unnoticed. And that's sometimes when those complications related to diabetes that I'll talk about later actually occur. And then the last section of that wheel that I'm going to address for the social determinants of health are education and access and quality. So with that, we want to ensure that education is equitable for everyone. Everyone has access to education. And what I do know is that individuals with higher educational levels, oftentimes they have more access and more information. And so we want to close that gap, and we want to make sure that everyone has access to that education, no matter what your educational level is. And that's important. So next, we're going to talk about diabetes specifically in North Carolina. So in 2020, the North Carolina Diabetes Advisory Council, they developed the North Carolina Diabetes Prevention Management Guide. And that information revealed that there is a high prevalence of diabetes in eastern North Carolina and western North Carolina. And then we reached the Piedmont, in which diabetes is around 11.4%. And now, specifically in Mecklenburg County, looks like statistics tell me that 9.9% of individuals in Mecklenburg County have diabetes. So again, diabetes is a public health issue and definitely deserves attention. So when we look at diabetes risk factors, so things that put us at risk for developing diabetes. So having a history of being overweight, abdominal obesity, so for men, that's that middle section that's over 40 inches, in women, over 35 inches. Physical inactivity, having a history of smoking, being over the age of 45, having a family history of diabetes, so genetics play a role. Certain ethnic groups, so African Americans, Hispanic, Latino, Native Americans, Asian American, Pacific Islanders, are all more at risk for developing diabetes. And then women that experience gestational diabetes or that had a baby weighing over 9 pounds. And then any individuals that have abnormal cholesterol or blood pressure readings are also more at risk for developing diabetes. So saying that, then you say, okay, should I get a screen? Who should be screened for diabetes? So if you meet that category, you fall into overweight or obese. So that's a BMI that's greater than 24. And I will tell you, in populations of color, that BMI index has been a little bit controversial because we all are little different sizes, shapes, and makeup. But Other things that indicate you should receive screenings are you have a first-degree relative with diabetes. Again, you're part of that high-risk race and ethnicity groups. You have a history of cardiovascular disease. You have high blood pressure, high cholesterol readings. Individuals, so women with polycystic ovary syndrome, periods of inactivity as well, and then other clinical conditions that could be associated with insulin resistance, which includes obesity. So how often should screening occur? So if you've been ever told, or you know someone that has been told they have prediabetes, often called impaired fasting glucose, if you have an A1C that's greater than 5.7%, you should be tested for diabetes yearly. People that were diagnosed with gestational diabetes, they should have lifelong screenings, and at least every 3 years. And then for all people, testing should begin at age 35. And if these results are normal, then testing should be repeated at a minimum of 3-year intervals. So I always encourage my clients, I always encourage people that I talk to in the community, if you've never had this screening done, ask your doctor, request it. I always tell people you are your own best advocate when it comes to your health, and that's really important. So I mentioned the term pre-diabetes earlier, and pre-diabetes is important for me to let you know that pre-diabetes is not diabetes, okay? It is a condition that can lead to type 2 diabetes. But blood sugar levels in pre-diabetes, they're higher than normal, but not high enough to be considered type 2 diabetes. If the doctor has told you that you have impaired fasting glucose or pre-diabetes, I want you to stay on top of those numbers and ask your doctor, hey, what are my numbers? I want you to look at your numbers and know what those numbers mean. And we're going to talk about what those numbers look like in maybe the next slide or two. So, for pre-diabetes, are you at risk? There's a lot of screens and risk factors. So, if you're online or if you're in the room and you want to know your risk, you can take out your phone, you can scan this QR code. It takes less than 60 seconds, I would say, to answer the questions here. But at the end, it's going to give you a summary, and you're going to be able to see, okay, am I at risk for developing prediabetes? And if you are, and you answered yes to some of those questions, then I want you to go back to your doctor and have a conversation with your doctor and say, hey, this is what I identified, let's talk about it. So with diabetes, long definition here on the screen. But with diabetes, what I want you to take away is that diabetes means two things. Either your body is not making enough insulin, or your body has become resistant to the insulin that it's making, okay? So that's what's going on with diabetes. So if you're resistant to insulin, or your body is not making enough insulin, then your body can't properly break down and process sugar. And so that extra sugar backs up in your bloodstream, resulting in elevated blood sugars, also known as diabetes. So I have another QR code here. And so diabetes, are you at risk? So this is through the American Diabetes Association. You can scan this, and again, about 60 seconds. You're gonna answer some questions, yes or no. And if you find that you're at risk, again, I want you to be able to talk to your doctor. You tell them, hey, I did the American Diabetes Association's little quiz on my risk factors for diabetes and prediabetes, and according to that, I have some risk factors. So when we look at the types of diabetes, now we're going into diabetes. So diabetes, you see type 1 diabetes, type 2 diabetes, and gestational diabetes. Type 1 diabetes is when the pancreas over time no longer produces insulin. Initially, when someone is diagnosed with type 1 diabetes, they may experience a period of time in which we call it the honeymoon period. So they actually still produce some insulin, but eventually an individual with type 1 diabetes will no longer produce insulin. The individual with type 2 diabetes, their body is still producing insulin. It's just not producing enough insulin, or the insulin that they do produce is become resistant to the cells. And then there's gestational diabetes, which occurs during pregnancy, and generally after the woman gives birth, blood sugars return to a normal level. So I talked a lot about diabetes, and so talking about how diabetes is diagnosed is really important. So anybody want to take a guess which the answer is? How diabetes is diagnosed? We've got the fasting blood glucose test, the hemoglobin A1C test, the oral glucose tolerance test, or do you think it's all of the above? What would you say? All of the above. That's right. So all of those tests can help identify diabetes. And so this chart kind of breaks that down for you. And so someone that does not have diabetes, if you were to go to the doctor, you were to get some fasting blood work done, normal ranges is blood sugar less than 100. 2 hours after a meal, if that individual should test their blood sugar should be less than 140. And that's milligrams per deciliter. Milligrams per deciliter is just a fancy term for measuring what the concentration of concentration of sugar in your blood. And then that individual that has normal blood glucose readings, their hemoglobin A1C should be less than 5.7%. Now, your hemoglobin A1C, that's just a measure of the amount of sugar that's been attached to your red blood cells over a 90-day period of time. So that's important because every 90 days, our red blood cells recycle themselves. So that helps our doctors know, hey, there's been a lot of sugar attached to the red blood cell over their last 90-day period of time. Then there's prediabetes or impaired fasting glucose, you might hear it called sometimes. When you get in that range, you get your blood work done, your fasting blood sugar is going to be somewhere between 100 and 125. And then 2 hours after a meal, if that individual was to test, they'd be between 140 and 199. And then their hemoglobin A1C would be between 5.7 and 6.4%. Now, you reach the diagnosis of diabetes when your fasting blood sugar is over 126 milligrams per deciliter, or we do a random test, and that test is over 200 milligrams per deciliter, or your A1C reaches that number of 6.5% or higher. So I always like to point out on this slide, if you look at the numbers between pre-diabetes and diabetes, I always tell people it's like you're walking the line. And so when you get that diagnosis of pre-diabetes, there are things that you can do to decrease your chances of going to diabetes. But there's only that 1 point difference, that range of 100 to 125, and then boom, you cross the line and you're at 126. So it's really important lifestyle changes, lifestyle management, to make changes to impact diabetes care. So what are some of the symptoms associated with diabetes? Now, I will tell you that some people don't have any symptoms at all. And some people, by the time they have symptoms, it's a little bit too late and the blood sugars are elevated. But things that can happen over time, subtle things that you might notice, is that you have frequent urination, you have frequent thirst, you're extremely hungry, you have extreme fatigue, blurred vision, you might have cuts or bruises that are slow to heal. These are all indications, all symptoms of diabetes. And it's just your body's response to help you try to get rid of that extra sugar. And then sometimes, like I said, some people don't have any symptoms. So why is this such an issue? What happens, I always say, when the glucose can't get into the cells to be used for energy? So if you have diabetes, you have this excess sugar that's backed up in your bloodstream, and you're not making enough insulin, or your insulin has become resistant to the cells, sugar has nowhere to go. So the sugar is going to build up to harmful levels in your bloodstream. And over time, this is going to cause damage to your organs, your nerves, your vessels, every part of your body. I once had a physician, and he used to say that diabetes was the mother of all illnesses. And since, being a diabetes educator, I was like, well, not quite, not exactly. I will say that unmanaged diabetes, it can certainly be the mother of all illnesses, because I have seen diabetes affect every part of your body when it is not managed, okay? But you have the power to manage diabetes. So now I'm going to talk about diabetes complications, because oftentimes when I see clients and I'm out in the community, a lot of times people, they fear the complications associated with diabetes. But those complications don't have to happen. So complications related to diabetes, as I was saying, diabetes truly can affect every part of your body. It can cause problems where you have heart attack, stroke, retinopathy or blindness, neuropathy, and kidney failure. And the reason is diabetes, when those blood sugars are elevated over a period of time, our blood was not designed to flow and be as thick as it is when that extra sugar is in our bloodstream. So when blood sugars are elevated, blood sugars, they damage the small blood vessels and the large blood vessels in our body. So it leads to what we know, they're called microvascular, which is those small vessels, and macrovascular, which is those larger vessels, and it damages those vessels in our body, which leads to the diabetes complications. So what steps should you take and how can you avoid these diabetes complications? So the first thing is something called diabetes self-management education and support services. And so that's where someone like myself, who is a certified diabetes care and education specialist, comes in handy. Because what we do is at diagnosis, we provide you education, okay? Annually, when you're not meeting your targets, we provide you education. And then when complicating factors occur, you might have some complications related to diabetes, and we want to provide education. And then when transitions in care occur, so different things happen. You end up in the hospital because now you've had a stroke or you've had a cardiac event. And then I come in and I provide education to you. So I always say diabetes education is essential to knowing what to do. And once you know what to do, you can manage diabetes. We call diabetes a self-managed disease. So steps to prevent complications related to diabetes include healthy eating, being active, developing healthy coping strategies, because having diabetes can take a toll on you. It's a responsibility and a lot of things to manage and do, and so for your mental health, you have to develop ways to be able to cope and talk about it. And then problem solving, so knowing what to do. Who are your healthcare providers that you need to talk to? How do you need to manage your care? What do you need to do? Do you need to check your blood sugars? That's all a part of problem solving. And then risk reduction for how you reduce your risk for developing those complications and being able to talk about it. And then also, do you need to monitor your blood sugars? So there's some people that must monitor their blood sugars. They take insulin, they have to do it. There's some people that have lower blood sugars and they have to monitor their blood sugars. So knowing that. And then if the doctor has prescribed medication for you, it's also important for you to remember that you need to take that medication, okay, as prescribed. So when we look at other things for self-care behaviors to promote change, and hopefully at the end you can ask me some questions, because all of those things that I mentioned on the previous slide, it's a lot more in-depth and steps that we can take and we can talk about there. But when we look at behaviors to promote change, those behaviors, when I say healthy eating, what does healthy eating mean? Healthy eating means that we're gonna promote healthy food choices. What are healthy food choices? Working with a registered dietitian to learn more about what those food choices are, that's important. And then we can learn carbohydrate counting and portion control. So I always like to ask people, okay, well, do you know what a carbohydrate is? Because that's important. So with diabetes, carbohydrates are the things that affect our blood sugars the most. But that doesn't mean that we can't eat carbohydrates. So now I'm going to ask the audience again, because we're talking about carbohydrates, but can you give me some examples of what some carbohydrates are?
French fries.
French fries, that's right. So French fries, so potatoes. What else? Somebody else, shout somebody. Rice, that's right.
Yeast rolls.
Yeast rolls. So you got bread, you got your starchy vegetables, so potatoes. You got your fruit, that's right.
Pasta.
Your pasta, that's right.
Everything good.
I always say, and that's right, Winston said it, everything good. Everything good, everything we like is carbohydrate. And so I want you to know though, don't be scared, because carbohydrates is not the enemy. I used to work with someone, she was a dietitian, and she said, We don't cheat with food, we eat food. And I'm a proponent of that. I'm from South Carolina, y'all. So I eat food. But it's important to know about balance when we talk about healthy meal choices and healthy options and portion control. So I didn't put this on the slide, but if you think about a plate, I always tell people, if you've got a 9-inch plate, that's one of those little round, tiny plates. Not one of them big square plates that everybody has in their cabinet right now. So if you take that plate, the largest portion of your plate should be reserved for what we call your non-starchy vegetables. So that's that things like kale, collards, mushrooms, zucchini, broccoli, carrots. Those are those non-starchy vegetables. You can eat as much of those as you want. Then you take that same 9-inch plate, and a quarter of that plate should be for your protein. So your meat, your lean meat, depending on how good your heart health is, okay? And then the other quarter of that plate is going to be reserved for those carbohydrates. So those starches, like you said, the rice, the pasta, those grains, okay? Then those vegetables that we said, the potatoes, the peas, the beans, those are starches. Or that roll, that's a starch, so bread. Then that fruit, or that milk and that yogurt, those are all carbohydrates, okay? But remember, doesn't mean you can't have them. You just need to learn how to portion control and how to manage it. Because I like food, okay? Now, the other thing there, self-care behaviors to promote change, is exercise. So, show of hands in the audience. How many of y'all like to exercise? Okay. Well, I'm going to tell you, I don't necessarily like to exercise. I always tell people if I could do it by osmosis, I would. Just close my eyes and think about it. But unfortunately, that doesn't work. So exercise, physical activity is really important. So it's important to incorporate at least 30 minutes of physical activity into your daily routines. So the American College of Sports Medicine and the Centers for Disease Control, they say, hey, you need to get 30 minutes or more, at least 5 days a week, 150 minutes of physical activity. So I know physical activity can be hard, can be a challenge for many of us. So I always tell my clients, think about it. Most of us eat 3 meals a day. We eat breakfast, lunch, and dinner, okay? In some way, shape, or form, we may have a snack if we don't eat breakfast. But I challenge you to start walking 10 minutes after breakfast, lunch, and dinner. And guess what that would mean? You get 30 minutes every day, just by simply walking. And so I often tell people too, physical activity does not mean that you need to join a gym, okay? I had a gym membership for years. And by the time I would get off from work, I'd put on my little clothes because I'm going to the gym. I'd drive past the gym that was on my way home and go home. So physical activity in that way, that wasn't working for me. So what I had to do was I developed strategies, and I watch YouTube videos. I watch YouTube videos in my little place, my little small apartment area, and I exercise. And I exercise at least 3 to 4 times a week. Now, I don't have diabetes. I always tell my clients that. Now, I've had a history of high blood pressure, so for me, I have to exercise to maintain and manage my blood pressure. So it's not something that I like to do, but it's become something that's become a part of my routine. And I'm not saying it's every day, but almost every day. Because the only thing I will tell you as well is that with diabetes management or managing any chronic condition, I always say it truly is what we're doing 80% of the time. We're not perfect because we're humans. So we aren't going to be perfect all the time in the way we manage diabetes. So 80% of the time, what we're doing is significant. The other 20% of the time, we got some wiggle room because we got life and life happens. And so that's important. We got to enjoy life. We enjoy celebrations. And we can't always get so caught up on what's going on with my diabetes. But it's important. All right, the other thing that's important there when we look at self-care behaviors is taking medication. So if your provider, your physician has prescribed medication for you, it's important that you take that medication. If that medication is causing you some discomfort, some complications, then you need to tell your provider, because perhaps there's another medication out there that you can take. Okay, because medications are truly going to be able to help you manage diabetes. Then other things that we talk about for self-care behavior change to promote change is healthy coping. So again, coping with life, everyday stressors that we experience, it's important. So you need to work on ways to manage stress and develop coping strategies when it comes to diabetes. Then you need to work with your healthcare providers. I always tell people this too, this is important. You find a healthcare provider that gets you. You find a healthcare provider that you are comfortable with, okay? Because you need to be able to go in there and talk to that provider, and that provider needs to be able to talk to you. So I know in the world of healthcare, which is probably why I got out of working in healthcare in a hospital setting, because I didn't always have time. Time was important to me, because time with my patients, my clients, is what mattered. And so if you don't have that provider that can spend that time and help you explain things to you, you look for another provider, or you see a certified diabetes care and education specialist who has the time to be able to talk to you. The other thing there is problem solving. So problem solving and learning strategies to take your blood sugar, maybe. Oftentimes, clients would tell me, Keisha, I don't want to stick my fingers, it hurts. And now, because our guidelines have changed through the American Diabetes Association now, and so monitoring is a little bit different than it was maybe 10 years ago. So if you're taking insulin, if you have low blood sugars, if you frequently have high blood sugars, you definitely need to be monitoring your blood sugars. If you just take certain oral medications or you're not on any medications, your doctor may not advise you to monitor your blood sugars. But things have changed. I tell people technology has changed. So now with monitoring your blood sugars, there's this nice little neat thing called a continuous glucose monitor. You can stick it on the back of your arm and it will monitor your blood sugars. So there's some certain criteria that you have to meet to be able to qualify for that, such as being on insulin, having low blood sugars, or experiencing high blood sugars, hyperglycemia. And then your doctor can perhaps write a prescription for that. But it's made managing diabetes a whole lot different. It's made it a whole lot easier for a lot of people that don't have to prick their fingers. I will tell you though, if you wear one of those devices and you get these high alerts or you get a low alert, I'm going to absolutely tell you pull out the old meter and check your finger, because you need to know what your blood sugars are. And working with a certified diabetes care and educator, we can help you develop strategies to make things a little bit easier so it's not as uncomfortable for you to do that. The other thing when it comes to problem solving, I always tell people, is learn how to meal prep. That's part of problem solving when it comes to healthy eating as well, because that saves you time. So just think about it. How many of you like to cook? You do? Okay, got some people like to cook. I like to cook too. When I got time, but I like to cook. But sometimes you don't have time to cook and you're on the run because you're busy. And so what do we do when we're busy and on the run?
Buy food.
Yeah, we buy food. We do fast food. So I always tell people, when you're managing diabetes or any other chronic condition, preparation really is key. And that's a part of problem solving. So for me, I know if I've really got a busy week, if I don't plan and prepare that meal on a Sunday, and I don't plan that meal out for the week, healthy eating isn't always going to happen. But I also tell people there's techniques we can do. We can get some frozen vegetables, pop them in the microwave, steam them on the pot on the stove. We can get little individually packs of salmon or chicken, and we can grill those or cook those. But again, that's all a part of preparation. Because if I, work all day and I get home at 7 o'clock in the evening, I'm not about to cook nothing. I'm not. So that's some of the things, again, preparing and planning, and we can do that with problem solving. The last thing up there I have is risk reduction. So risk reduction is important. So you participate in education to reduce your risk of complications. You learn, how do I manage these diabetes-related complications, and what do I do? And then the other important thing is you schedule annual examinations and request screenings from your providers. So again, as I was telling you, reach out to your healthcare providers. I believe once you have an established healthcare provider, it's a little bit easier to schedule those annual appointments. But again, if you don't have someone established that you've been seeing, it may be a challenge to find a provider. But participating in education is important. And so if you've been diagnosed with diabetes, you have some renal issue, I'm going to tell you, whatever issue you have, you talk to your doctor and you say, hey, I need some education on this, and advocate for yourself. And then the other thing is scheduling your annual examinations and request screenings. So a few slides back, I talked about, if you were at risk and you needed to be screened. So talk to your doctor about that and say, hey, I meet some of these risk factors. I have a family history. I know I have a little bit of abdominal obesity. I had gestational diabetes, and I think I need to be screened for type 2 diabetes. And that becomes important. The other thing I often tell people is know your benefits. Know your healthcare benefits and what your healthcare coverage will cover. So know, if you have diabetes, what medications can you take? If you have pre-diabetes, okay, what can you take? If you know that you are not exercising and you have reached that category where the doctors consider you as being overweight or obese, what medications is available to you? There's a lot of weight loss medications out there now that help us manage weight, that you don't have to have diabetes for some of these, but know the medications and what your insurance covers. Then the other thing is with diabetes supplies, your glucose monitor and your other supplies. Know what benefits you have. Call your healthcare insurance provider. Talk to your pharmacist about what's available. Then with your diabetes screenings, know what's available if you have Medicare. Medicare open enrollment just ended on Sunday, I think. But you get that book, Medicare and You, annually. So look in there and see, what diabetes screenings am I eligible for? What diabetes screenings should I be receiving? And then knowing your benefits for diabetes technology. So if you have type 1 diabetes, and some people with type 2 diabetes, they actually qualify for insulin pumps. Or do you qualify for that continuous glucose monitor? Remember I was saying you sometimes have to meet certain criteria for that. But do you qualify? Find out. Ask those questions. And then specialized orthopedic footwear. If you have diabetes, if you have Medicare, if you have even some other private insurances, you have a problem with sensation, you have a problem with your feet and you're seeing the podiatrist, there's specialized footwear that you may be able to qualify for. And then diabetes self-management education and support services. So diabetes self-management education and support is a service that is covered by Medicare and is covered by private insurance. I will say it's different for each, the cost of what's covered. If you have Medicare, definitely take advantage of that benefit. And that benefit is an hour of individual education and about 9 hours of group education. Some people, they prefer to see me, an independent diabetes coach, because that's individual one-on-one time. Unfortunately, I do not take Medicare for that service. Then we have special eye exams. So following up with the ophthalmologist, the optometrist, to be able to get those screenings and knowing what's covered there. A lot of times I'll tell you, it is the ophthalmologist that actually identifies diabetes in individuals, because they go in, they do that assessment, and they look in your eyes, and they say, okay, something's wrong with those tiny blood vessels in your eye. And they're able to say, hey, have you ever been screened for diabetes? And a lot of times they are the ones that discover it. So special eye exams that you need, make sure you get those on an annual basis. And then the other thing is medical nutrition therapy. So we often call that MNT, and that's working with a dietitian. So if you have diabetes, that would be good. If you have problems with renal function, whatever problems you have related to diet, the food that you eat, oftentimes a registered dietitian is going to be the individual that's helpful in helping you manage that care. And then there's resources for you in your community and knowing what those resources are and how to get in touch with individuals. So definitely me, diabetes coaching programs such as my organization, Weldon, the National Diabetes Prevention Program. This is a program that's run through the CDC. This is a program for individuals who are at risk for diabetes. It's a year-long program. And most of these programs you meet off-site at community centers. Some hospitals offer them, and some programs are online. Then there's Medicare diabetes prevention programs that you can actually locate in your area. Then there's hospital-based self-management programs that you can find out more about. So the bigger healthcare systems here that have diabetes programs. And then the Endocrine Society. The Endocrine Society is made up of endocrinologists, and endocrinologists are physicians that specialize in the management of diabetes. Now, I will say your primary care physician can manage diabetes as well, but endocrinologists, they are the specialty when it comes to diabetes care. So if you are having challenges with your diabetes, your blood sugars aren't well maintained, I definitely would encourage you to seek out an endocrinologist or the Endocrine Society for more information. And so on this slide here, this is how you can get in touch with us at Weldon. That's our social media handles, our website, and our email address. And so definitely I would encourage you, if you have diabetes or pre-diabetes and you want more information, I definitely encourage you to reach out to me. And on this slide, what I want you all to do is I created a YouTube channel. And I created this YouTube channel because I wanted to be able to bring access to community members that I serve who may not actually go to a diabetes education class. So each week I do a little episode and I do little tidbits because remember, I can't give you all the information on YouTube, but I have a YouTube channel. I am Keisha Lewis. You can find it there. But I want you to pick up your phone. I want you to scan that little QR code, and I want you to hit subscribe so you can see me each week, each Wednesday. I give you a little bit of information, just little nuggets. But that was important to me because working in a hospital, it was so many times that I found that hospitals did not have diabetes educators, that physicians and nurses did not have the time, no fault of their own, but they did not have the time to provide education to their clients. So while working in a hospital, I said, I wish my clients had something, a QR code that they could scan when they were laying in that bed to learn some tips about diabetes. So that's what I kind of created for that purpose. The other thing, just to let you all know, I have recently, I wrote a little book called Type 2 Diabetes for Beginners. So if you're interested in my book, let me know. Purchase it. It's also available on Amazon. But now, because I want to have some time for questions, so I'm going to turn it over to the moderators, but I'll answer any questions that you have. I always have to probably talk about diabetes all day. But any questions that you have, so go for it.
Thank you so much, Keisha. I'm going to start it off. I got a question because I saw risk factors. And with all of the medical terminology and, you know, all of the things that also up there, what I need to be impacted is black folk. So is like diabetes, like sickle cell, like just by being, is it innate of blackness or like how does?
So I would say it's like sickle cell, but diabetes, it impacts more minorities. And so if I go back to, I always like to think about the African diaspora and, you know, as we cross that continental, you know, United States and our habits change and our food habits and over the years, how life has changed and the food has changed and the way that, you know, we used to be more active in farming and doing things. Over time, I found that it's occurring more in people that look like you and I. Whether that's eating habits, Whether that, again, is those social determinants of health, because there's no access to good quality care. I'm not going to the doctor because there aren't doctors that look like me, and I don't have anybody to keep it real with me, because I'm going to always keep it real with my clients. I always. And so I believe that some of the behaviors, some of the community factors, some of the societal factors have contributed to the increase in diabetes, as well as our food and our eating habits have contributed to this increase in diabetes. And again, exercise. Do we get enough exercise? The emphasis on that. And when you talk about diabetes management, I always tell people, diabetes management, chronic disease management, a lot of times in the United States, in modern day medicine, we are very reactive. We're not proactive. So education starts when, we're little. So starting to educate and teach our children about healthy habits and healthy eating, it becomes really important. Because the emphasis on exercise, physical activity, eating your fruits and your vegetables, looking at those carbohydrates and not having a full plate of those carbohydrates, that's ingrained in us. When I grew up, I had rice every day, rice or potatoes. I don't eat rice now. I really don't. I got alternatives to it, don't get me wrong. But some of those things were how I grew up. And so it wasn't until I got older that I started making behavior change. And those behavior change really can impact, us as Black people, and be able to make those changes. But again, we got to talk about it. Because if you tell me to go get some zucchini and zoodle it, and I'm like, what you talking about? Or I tell you to go get some cauliflower rice, when your mama's been giving you rice every day, you're going to look at me a certain way. But if I cook that and prepare that and tell you, ooh, we can make that good because we can take that cauliflower rice and we can turn it into some dirty cauliflower rice and we gonna think we have Bojangles. But it has to taste good.
Absolutely.
So we can do that though. But if nobody teaches us, we won't know.
Thank you so much. We got Miss Jackie.
Good morning, Keisha. Good morning, Keisha. So glad that you could make it back. I wanted to ask you, having been here for 10 months, have you made contact with any of the Medicare primary care folks, such as Patina, Centerwell, Oak Street Health, Archwell, Dedicated, and also have you made contact with the health department with their Village Heartbeat?
Okay, so to answer you, Ms. Jackie, so I have made contact with Patina Healthcare, with Centerwell, and with Archwell. I've done a few community presentations with them, in which I've gone out to some of the independent living communities here in, I think I went to one right down the street. I can't remember which one it was, but I've gone to several community centers to reach out with them. I'm also currently in 2025, not quite yet official, but I'll be partnering with the American Diabetes Association to do something in some capacity out in the community. And I have not made contact with the health department here, so I will look into the health department and Village Heartbeats as well. But yes, just being here 10 months, I'm definitely trying to reach out and partner with people to make an impact, because as I said with diabetes, it is a self-managed condition. It can be managed, and we don't put enough emphasis on communities of color, as Winston said, Black people that look like me. And so that is the individuals that I often see impacted the most by diabetes. And a lot of that is, hey, I remember I told y'all I'm from South Carolina. A lot of that sometimes is, I'm going to eat what I want to eat. I'm going to do what I want to do. And if it's not bothering me, I'm not bothering it. But I always tell people, just because diabetes isn't bothering you, it doesn't mean that it's not wreaking havoc in your body. Okay? So.
Sorry for getting here late, had
No,
car issues, but it is so refreshing to hear someone of your age range, and I'm going to suggest you're less than 50 for sure to be safe, But during the pandemic, I would ride by a club up on Moorhead Street. It's Wilkerson Boulevard. And that was when the pandemic was in its height. And I would see young black adults just having a great time, and maybe 300 of them and not two masks in the crowd. So my issue isn't with people like me at 76, diabetic, and a recent prostate survivor. It's not so much my generation as I'm concerned about the young people who don't take a lot of this stuff as seriously as they should. And then we have these great professionals like you who come and talk about the disparity of us in these variety of areas. There is something to be said about accountability and responsibility that a lot of young people who are at risk of a lot of this stuff and who are directing their lives toward the downside of diabetes and other issues, they don't take responsibility for it. And that really distresses me to see the lack of seriousness by a lot of our young people, and especially people of color, because then we go around and tout the fact that we're disparities in various categories, but it's because of our own undoing. So do you have a target group that you try to really stress what it is you're trying to get across?
Thank you for that. So when I first started this journey and when I first moved here, back in January 19th of 2024, my target was to target older adults and persons with diabetes. And primarily because I often work with older adults, that was my comfort and that was my desire. But in being here for the last 10 months, similar to what you said, I see but sometimes, just like you said, it's easier for me to reach you, okay, or you reach out to me. So what I've learned is, again, as I was telling Winston when I answered that first question, is a lot of times people don't realize that these issues impact them. And so I think, again, talking about this at a young age, the American Red Cross has a project. It's called the Pillowcase Project. And what they do is they go into elementary schools and they talk about fire safety and packing a pillowcase and getting that home to mama. So I participated in that project once. And so I was amazed that the principal of the school called me back and she was like, you know what, Keisha, I had so many parents coming to me saying when their kids got home, they taught them about the Pillowcase Project. And they said, Mama, we gotta build a bag and we gotta get ready and we gotta make a plan because if a fire happens, we gotta get out of the house. So I think we gotta change the way we think. I think we have to start at the elementary level, and we as a society, me included, have to figure out a way to tackle and reach out to those kids, because those kids go home and they talk to their grandparents and they talk to their mom and their dad, and then that's going to influence the mom and the dad. And then I have to get places where the moms and dads go. So a lot of projects that have focused a lot on communities of color. You reach communities of color by going into communities where they are. So in your example of where individuals were and during COVID-19 and they were, in this parking lot, those are probably the parking lots I need to be in. But again, I have to do something that appeals to that audience, because me reaching that audience is a lot different than me reaching you. But I don't want to give up on that audience. So I gotta find a way to connect with them. And that connection, I think, starts with their children, which is gonna send a message to them, and then getting in a place where they go. Because a lot of times they don't realize the impact of obesity. They don't realize the impact of eating high salted sodium fast food. So, I always say we live in a culture now, a society where, we love food. You know, there's things on social media, and I'm not a big social media person, but I'm on there sometimes. But on Facebook, it's something called Big Bag Eating Group or something. And I was like, whoa, wait a minute, but that food looks good. So we've become obsessed with food. So how can I take that same culture and obsession of food and turn it into a culture and obsession with, talking about diabetes? And so I got some ways and ideas and thoughts on how to do it, but in the culture we live in, we got to find creative ways to connect with our community to be able to talk about issues that matter, that affect the community. Okay?
Carrie?
With respect to your comment or your what you said about your difficulty finding a primary care physician, it is really difficult, but my primary care is taking new patients, so I'd be happy to share. But anyway, and she does not look like you. I'm gonna be honest. She looks more like me. But our country has a healthcare crisis.
Mm-hmm.
She left a big hospital system because of the way the system was not working for the patients. Thank goodness she's still practicing. But if you need a specialist, you wait months and months. And what she said to me when I talked to her about this is that we have a bad attitude about so-called socialized medicine or single-payer systems, but we basically have socialized medicine here because of the way our system is not working, if that makes sense. Because we have to wait so long for specialized care. So, I don't know if you have a comment about that, but that's...
No, I mean, what I would probably say is you're right. Our healthcare system isn't working. And that's really why I created my organization, Welcome. It's because I was finding that things working in a hospital, in a big healthcare hospital system, similar to what your experience was with your doctor, it just wasn't working. Care is quick. It's about time. It's about productivity. I can't spend a lot of time with my patients. It kind of went to the have and have-not sometimes in healthcare. And I'm going to always be who I'm going to be. And so for me, I had to get out of healthcare because I figured I could make an impact, a better impact. I could say what I wanted to say, do what I wanted to do, and be my own. So that's kind of where I am. So we have to find, I don't know what the answer is, but we have to find a better way to do things that we're doing. And right now, I talked about earlier the Affordable Care Act and how the Affordable Care Act impacted a lot of people in a positive way. The Affordable Care Act is in jeopardy now. So there are going to be more chronic disease. There is going to be more diabetes. It is going to be more diabetes, chronic disease in all communities, okay? Because things have changed. And so to be able to answer the call and to be able to talk about this, it's going to take people like me, like your provider, like some other providers that I've met who've decided, I'm not taking Medicare no more. I'm doing concierge medication, which everybody can't afford concierge medication. So we got to figure out a way to make it work for all people, not just the people that have the money to be able to pay for, that concierge care. But it's going to take a group of, I always say, innovative, creative people that work in healthcare who aren't afraid to talk about the issues to make a change and not afraid to leave big business, big healthcare hospitals and healthcare centers because, that's the only way that we're going to really make an impact is get back in the community to help those people.
All right, we have Ms. McClellan, Ms. McElroy, and then I have a question. Then Ms. after Walk.
Yes. Okay, my question is in reference to inheriting diseases, because you're here, and the doctor, you go to the doctor, they want to know your family history, and And I've heard several people say that diabetes runs in my family. And how is that? How real is that? Because you hear a lot of that. And I inherited, it's in my family. So, and with the history being asked, and of course, when you go to the doctor, of your family history, they want to know, they want to have high blood pressure, that they have diabetes or anything like that. And in my family, no one in my family, none of my siblings, there were 9 of us, had diabetes. So, but we're obese, we have other illnesses, but that is one thing that I like for you to just share with us about that being real, the truth about that.
So that is real. There's some truth behind the genetic component of diabetes. So with diabetes, I always like to tell people why it exists. We don't know why diabetes exists, but there are certain things that put us at risk. And one of those risk factors is family history, so genetics. So I always say too with high blood pressure. People look at me and they say, well, you can't have high blood pressure, you thin, you work out, but my family has a history of high blood pressure. So when I was 20 years old, I had high blood pressure. So genetics. So there is a strong factor in the genes and family history that contribute to a lot of these chronic diseases that we see, like diabetes. So you're absolutely right. You all might have other things going on, but you don't have diabetes. But if you had diabetes in your family, you might see. And then there are some people sometimes that they don't have a family history of diabetes, but they later go on to develop diabetes. And so we generally say, particularly for type 1 diabetes, that you didn't hear me mention a lot about, but if you have a first-degree relative, mother, brother, sister, you're more at risk to develop diabetes.
Good morning, and thank you for being here. I was told to just avoid all white food. Now, be a way to keep down your cholesterol. But what about whole wheat food? So is whole wheat bread okay or just better?
So, this is what I'm saying. So I always, as a diabetes educator, me being me, I hate when people tell people to avoid all white food, because you know what? You like some of that food. And so what I say with that is, as it relates to diabetes and carbohydrates, it doesn't matter. A potato is a potato. If it's a white potato or a sweet potato, the only difference is the sweet potato has more fiber. Then if it's white bread versus brown bread, the brown bread, wheat bread has more fiber. So to your point, it's better because you have more fiber in that particular food, and more fiber is going to be good for helping you digest things better. It's giving you some more, nutrients. It's going to help you be able to go to the bathroom better. So fiber is better. So having some options are better than other options, but at the end of the day, it's still the same food. Whether it's brown rice or white rice, the brown rice might have a little bit more fiber, which might keep you full longer when you have something that's more fiber-rich food. But essentially, you just portion control. If you prefer the taste of white rice or that potato, then I'm gonna tell you have it and just portion it out, okay? But don't avoid it, because if you eat that brown bread or that, sweet potato, it's still gonna impact your body the same way, okay? Yeah, but I had a doctor tell my aunt that too. And then she did.
What's the doctor that told you?
Oh, well, I had a doctor tell my aunt that. My aunt, she gave up everything. And she did good. It was because she had pre-diabetes. Gave up everything. It was during one Christmas holiday. I'll never forget it. She gave up everything. And she was like, I don't have diabetes no more. And she lost all this weight. Time as Christmas was over, that joke, she went back to eating everything. She gained that weight back. And she was like, Keisha, my blood sugars went back up. I said, yeah, of course they did. I was like, because you went back to the same way you was doing before that doctor told you not to eat all that stuff. So you gotta put it in context, everything. Yeah, moderation, that's right, moderation.
All right, Ms. Felix.
Good morning.
Thank you for being here. I have a question about some of the new weight loss drugs that are out now, like Ozempic and other brands that are targeted for people that are overweight, but they say they were first initially for people with diabetes. Does that cause a person, if they're taking, I don't know if you know this answer, but if you don't have diabetes and you take something that was targeted for people to lower their blood pressure, can that make you have diabetes?
So you're right. So those medications, those weight loss medications, they're in a class of medications that we call GLP-1s. And those medications were originally created for diabetes, some of them, because they were helping with gastric emptying and how the body kind of processed that sugar. But they have now made medications that target weight loss, and they're not for persons with diabetes. So example is like Wegovy. It is a weight loss medication, but it's not intended for someone that has diabetes. A person with diabetes would take Ozempic. So there's different classes of medications for either the person that's targeting with weight loss and diabetes versus the person just targeting for weight loss. And so no, if you take those weight loss medications, it's not going to put you at risk for developing diabetes, okay? Some of those medications may increase your risk for a lower blood sugar, but that's not common. But it's not going to put you at risk for developing diabetes. Weight loss medications have been life-changing for a lot of people. Because what people often think of when they think of someone that's overweight or obese, sometimes people, they look at you and they judge and say, well, you ate so much food, or you did this or you did that. But what we know about obesity is that obesity is a disease just like other chronic diseases that people experience. And so I'm not an obesity medicine scientist specialist by any means, but we do know that there is a chemical imbalance in the brain when it comes to obesity. And so those medications can target some of those impulse areas. And so those medications have been very helpful for people who could not naturally lose weight by exercising or, changing things in their lifestyle. So there's a place for obesity medication for people, and the coverage for that medication has changed over the years. And people that are obese, overweight, that do take some of those weight loss medications, it actually helps them to be able to manage some of those chronic conditions like diabetes or high blood pressure as well. So no, it won't cause that diabetes to occur.
All right, I have a question then, Mr. Coombs, and we're going to go to announcements. So just on kind of the trajectory of Ms. McElrath's question about the carbs, what are some of those narratives that you often see where people can be fooled by, thinking this is natural or thinking this is a vegetable, so I'm fine, I heard that like a handful of grapes is pretty much not that far from a handful of Skittles. So, but again, grapes being produce, you have an idea that this is better for me, or I can eat sweet potatoes because they're better than white potatoes. So what are some of those narratives that people often take and run with?
I think one of the biggest ones was what she said, is that about the white food versus like the brown food. Just like you said about the fruit, I always tell people, just because it's fruit, which fruit is healthy, but you can't eat endless amounts of fruit, because endless amounts of fruit will raise your blood sugars. Now, in your example about your grapes, about 17 grapes is about a serving of carbohydrate. Sometimes you get ridiculous and you can eat a whole bag of grapes. So if you did that, it'd be about as bad as eating Skittles. The other thing I hear often is, people have a misconception that, and I used to have a coworker who used to tell me this, and I always say, I'm not going to offend anybody because I'm going to say it the way she said it, because it's her words, not mine. But she would say, Keisha, just because you're skinny on the outside, you can be fat on the inside. And so that's sometimes a misconception. It's because you look a certain way, you're healthy.
because, I'm thin, I'm healthy. I couldn't possibly have high blood pressure or high blood sugars. Or because I'm larger, oh, you got diabetes and you got high blood pressure, and you may not. So sometimes that's a misconception. So that's why I tell people it's important to exercise. Let me try to think of something else. It's always, the other misconception with diabetes is that everything is about food. Your blood sugars get high because of food. You got to cut out food. You got to do that. And I tell people, no, that's not it. I got a YouTube episode coming up, and it's going to be, I got 42 problems, but sugar and food is just one. So stay tuned. Because food is only one problem with diabetes. There are like 42 different factors that affect your blood sugar, including stress, including medications you take, if you don't get enough sleep. There's so many things that can impact your blood sugar, but a lot of times people focus on diabetes and just food, and that's incorrect.
All right, we got Ken and Miss Jackie, and we're gonna see if we have time for announcements.
Okay.
So we can keep questions to 30 seconds and answers to a minute.
Socialized medicine versus care, and big pharma versus holistic type medicines. And as a diabetic, I've seen some of these commercials for diabetes. And when I see those commercials, and then they tell you in a minute commercial, 20 seconds about the positive impact, in the next 40, they're telling you about the side effects. I said, no, I'm good. Thank you very much. So tell me about the differences, how you feel in regards to holistic approaches to medicine and treatment for a variety of things like diabetes compared to the big pharma, who basically takes aim at the holistic approaches, which in fact many times have shown greater tendencies to control some of these diseases versus the big pharma pill pushing.
Okay, so with that, I'll say I'm all about lifestyle changes. I'm all about, with diabetes management, and you'll know I have medications on one of those slides at the end, but it is a lifestyle management disease. So if an individual is willing to really work on that and change their eating habits and increase their activity and cut out, some of those carbohydrates, and it can be managed with lifestyle. But then there are some times where, you do it for so long and your body becomes really resistant to insulin and you need some medication to help you out. But I'm gonna always go with the lifestyle route first. But then there's some times in which someone does need medication. But that's not always my first answer, okay? Because what I will say is sometimes I like to use this analogy is your body is like a car. The older your car gets, the more repairs your car needs. So as our body gets older, what we do to manage diabetes initially and in the beginning with lifestyle changes, we just can't always do that because stuff starts to break down and we need that medication. So medication, yes, it is a lot of side effects sometimes that we see and hear about. But talking to your doctor about the percentage of times those side effects happen to certain people, because I know they give you all kinds of stuff and be like, oh Lord, I'm not taking that. But lifestyle change, I'm definitely a fan and an advocate before you have to get on medication. But sometimes we have to.
All right. Ms. Jackie.
Yes, I wanted to just say that, Village Heartbeat is made up of 40 plus African American churches by way of the health department. About more than 300 people are a part of it every year. So hopefully you'll connect with them. And many of those folk have the metabolic syndromes. So I want you to know about them so that you might connect. Also, can you speak a little bit toward, you go to an early morning breakfast and you see all those pastries and fruit.
Yep.
And there's never any peanut butter or eggs or cheese, that protein that needs to be together. Can you speak to that?
Yes, ma'am, I certainly can, because it's very interesting. I went to a breakfast a few weeks ago, and it was a breakfast with physicians and some diabetes educators, and a whole lot of other people. And a lady speaking on the panel, she called everybody out. She was like, you want us to eat better, and you talk about eating healthier and having healthier options, but when you have events for us, you bring the bagels, the apple juice, the orange juice, and muffins. So again, it's a mindset and a change. You know, we bring stuff that's cheaper, that's gonna fill people up. So at that next breakfast or event, I would encourage you to think about what are your healthier options. And fruit isn't bad. So if you have fruit, just remember you gotta break it down and do portion control. But then, you know, hot breakfast is a little bit higher. So yeah, it would be nicer if we had some eggs with protein and maybe some other little protein for meat. But that's a challenge sometimes, and I recognize that. But throwing in, like you said, the meat, the cheese, the nuts, yes, I would encourage you. So at your next event, think about that, and don't bring those big bagels and muffins, and do something on the lighter side.
Next week.
All right, ladies and gentlemen, please give it up. Thank you so much, Keisha. And also, we don't have time for announcements, but please join us at our Carb Heavy Christmas party next week, Tuesday morning at 8:30, where we will have all of the things Keisha told us to stay away from. That will be so delicious. Keisha, we are keeping you in business because it will be a lot of education necessary in January. But
we are having eggs and we're having protein. You just don't.
yeah, I'm completely joking a little bit. But yes, that is absolutely right. But next week we are having our annual Tuesday Forum Christmas party. It will be amazing catered breakfast by City Councilman James Mitchell. Bring a gift unwrapped, kind of white elephant-ish, right? Just bring a gift unwrapped. What else, Ms. McGill? Anything else?
Because we'll be playing games.
We'll be playing games.
The party requires no knowledge.
The party requires no knowledge.
Come to have fun.
Come to have fun, and again, that is next week. Thank you so much, Keisha. We appreciate everything.
Don't forget, if you bring a bottle of wine next week, chances are you'll be able to keep it.
If you bring a bottle of wine next week, chances are you'll be able to keep it. Oh man, because.
Don't even ask him. Don't even ask him.
Well, thank you so much, ladies and gentlemen. We will get out of here. Join us next week for the party. That will be our closing Tuesday, and after that, we'll see you in 2025. January what? 7th. January 7th. Hey, Shay.